NIAP C516, Nociception and Pain. The topics we'll cover in this presentation include where the pain is experienced and how the nature of the pain, the words used to describe the pain, can give us clues as to the originating tissue. We'll go over accepted definitions of terms regarding nociception and pain, theories regarding pain, and the anatomic basis of nociception and pain, how that system goes awry in chronic pain, and how our orthopedic manual physical therapy techniques are proposed to reduce pain. In general, pain is experienced at the location of the stimulus or somewhere else, or both. This is starting to look like my patient population. An article written by Nikolai Bogduk in 2011 called The Anatomy and Pathophysiology of Neck Pain is a detailed critical analysis of the evidence for the sources of neck pain. He goes through in detail identifying structures that are capable of nociception and then looks for the scientific evidence in normals or patient populations for those structures being causes of neck pain. As evidence of the structures which could potentially cause neck pain, Bogduk identifies multiple large studies which he extrapolates an approximate prevalence from this metadata. Tumors are found to be quite rare, but of course serious, and at least as likely to cause a painless radiculopathy by nerve compression without inflammation as they are to be a cause of pain in the neck. Fractures are also quite rare, even in trauma. Only 3.5% of individuals with neck pain are positive for a fracture. Vascular structures were not studied in relation to neck pain, but there is a clear potential for it. The aorta, when it tears, rarely presents with only neck pain and has concurrent cardiovascular distress. The internal carotids, also rare with only neck pain. The vertebral artery, 50% of the time, initially presents with neck pain, usually progresses into headaches, and there are often concurrent VBI findings. Systemic disease, such as rheumatoid arthritis or other inflammatory diseases, are rare to present only in the neck, but are known to cause pain in the neck. Synovial cysts are an uncommon cause, which are more likely to cause radiculopathy than pain in the neck. Torticollis is a clinical syndrome, not a diagnosis, and it can be triggered by facet joint subluxation or other neurologic causes. Paget's disease, an abnormal bone metabolism, is typically painless, and if it affects the neck, it is rarely the only site. With regards to the common diagnoses of spondylosis and degenerative disc disease, these have a very poor correlation with pain. Their incidence increases over time with age, which cannot be said about neck pain. Psychogenic causes of neck pain are no longer accepted by the DSM-4 as a valid diagnosis. Muscles have not been studied as potential causes for neck pain. As with tendinitis, it is a dubious diagnosis. Trigger points are also not well validated, often found immediately overlying tender facet joints. The ligaments have not specifically been studied, but they are generally pain sensitive in other places in the body and may be covered under the vague terms of whiplash or soft tissue injury. The dura has not been studied as a cause of neck pain, but dural inflammation is more likely to generate a non-segmental pattern of neuropathic pain. The disc has been widely shown through provocative discography to produce pain, but it rarely is able to identify one level as the source of pain. In most individuals, multiple levels will be positive, and it is a doubtful test for the true causes of pain. The facet joint is the best studied and most validated cause of neck pain. In normals, by means of mechanical and electrical stimulation, you can produce neck pain locally or in a referred pattern into the limb, upper back, and head. Anesthesia can relieve that pain in patients and has been performed in double-blind studies. So in summary, most of the common structures which are attributed to neck pain have limited or no evidence to support that. And the single most likely structure to reproduce neck pain, chronic or otherwise, is the facet joint. As we said, pain can either be local from nociception occurring in that tissue. This produces a dull aching sensation in the area where nociception is occurring, or we can have somatic referred pain where a proximal tissue is experiencing nociception but is experienced distal to that. This tends to be a much less localized and vague sensation, dull, aching, gnawing, and it has a sense that it spreads out and settles in a particular region. Radicular, or in other terms, neuropathic pain, is due to inflamed nervous tissue that has been damaged, the dura has been sensitized by inflammation, or the dorsal root ganglion has been compressed. This produces a sharp stabbing pain that travels in a narrow band down the limb. It does not follow the same pain pattern as referred pain. The proposed mechanism for pain referral is a condition where multiple afferent fibers converge upon a single second-order neuron. When one of these afferents is activated by nociception, it triggers a response in the second-order neuron. The signal is sent up to the brain. However, the brain misperceives it as coming from a different afferent fiber than the one it actually came from. But that fiber is associated with a structure from the same embryologic level as the original fiber. This is somatic referred pain. In the example of the C23 facet strain, we have our dull, aching, localized pain, and it can refer in an occipital, temporal, and frontal region, and is often described as settling behind the eye in the somatic referred pattern. Radicular pain patterns, according to Bogduck, produce that lancinating pain that travels down the limb. Radicular pain is not purely a nociceptive phenomenon, given the large concurrent discharge of the A-beta axons, not just A-delta activity. It does not follow the cutaneous pattern or dermatomal pattern that we are accustomed to. It will be most consistent with the muscles of innervation at that particular level. So as an example, C5 will tend to refer into the upper arm, and C6 through 8 can travel into the forearm or the hand. In the example of a C5-6 disc with C6 nerve root involvement, we have the dull, aching, localized nociceptive pain, and we also have our lancinating band of pain that travels down the arm. This may be concurrent with a radiculopathy. Which is an alteration of sensory, reflex, or motor function, regardless of pain. In C5-6 traumatic arthritis, we have our local pain, and we have our somatic referred pain that goes into the limb. It's wider than the pattern we saw in the nerve root, and it does not have that rapid sensation to it. It is that spreads and settles experience. If we look at some of the studies that have been done on the referral patterns for provoked discs as well as provoked facet joints, we see similar patterns of distribution because these structures all come from the same embryologic level. Ian McNabb classified pain according to the system that was involved. This can be a clue as to the type of tissue which is producing the pain. Viscerogenic is quite difficult to localize and may have a cramping, diffuse nature to it. It does not move rapidly. Vasculogenic pain is also diffuse and aching, but tends to have a pulsatile nature to it. Neurogenic is that sharp shooting pain, electric in nature. Psychogenic is described with affective terms such as annoying, dreadful, terrifying, and as said before, is no longer a DSM acceptable diagnosis. Spondylogenic pain is dull, localized aching. And systemic varies in its presentation, and pain is usually not the only symptom. We have tools which can help in identifying different types of pain, particularly ones that may be involved with maladaptive pain behaviors. The McGill and the Fear Avoidance Behavior Questionnaire, which has a version sensitized for the neck. The dominant theory for pain currently is that pain experience exists within the individual's attitudes and beliefs, is impacted by their psychologic distress, creates their illness behavior, and this all occurs in a social context. Nociception is a process that involves many structures. In the periphery, there are receptors and fibers to the cord, the brainstem, and eventually the cortex. The peripheral nociceptors are found muscles, blood vessels, the meninges. Fibrocartilaginous structures have been shown to have nociception, although not all studies agree. It's typically found in the most peripheral aspect of the fibrocartilage and not found in the central aspect. Ligaments have free nerve endings. The epineurium has free nerve endings, but they are not compression sensitive. They are chemically sensitive. The synovium also has some nociception. Free nerve endings are not found in our articular cartilage, the hyaline cartilage of our joints, and in a significant portion of our fibrocartilaginous structures. However, the subchondral bone underneath the cartilage is highly innervated. Our triggers for are chemical, mechanical, or thermal. The fast pain system, the A delta fibers, are myelinated with a larger diameter. The slow pain fibers are unmyelinated and have a smaller diameter. Fast pain, like putting your hand on a hot stove, is transmitted at a rapid rate, triggering withdrawal reflexes prior to the experience of pain within the cortex. Slow pain from C fiber input takes time to come on and time to go away. The spinal cord is where the peripheral nerves end, coming in the tract of Lissauer, and then in the case of the A delta fibers, in the first lamina, or in the C fibers in the substantia gelatinosa, which is the second and third lamina of the dorsal horn. Once transmitted to the dorsal horn, that pain information is relayed up into the brainstem. Key areas of interest in this region are the periaqueductal gray and the thalamus. The spinal thalamic tract is the primary pain pathway, and for the head, the trigeminal thalamic tract. The cortex is where the nociceptive information is interpreted and valued. That's when nociceptive stimulus can become pain. The International Association for the Study of Pain has been active in unifying the terms with regards to pain and nociception and clarifying the research with regards to pain. The following are their definitions. Pain being described as a sensory and emotional experience. Nociception, which is the encoding of noxious stimulus. Nociceptive pain being pain that arises from tissue which is actually or potentially being damaged by means of activating the nociceptors. Paresthesia is an abnormal sensation. Dysesthesia is an unpleasant abnormal sensation. Causalgia is a syndrome whereby a burning pain experience can be stimulated by non-painful input or is disproportionately experienced compared to the stimulus. This occurs in damage to the nerve, dorsal root ganglion, and is also associated with autonomic changes and eventually trophic changes, similar to what we see in complex regional pain. Hyperpathy is an excessively painful response to a stimulus, particularly when that stimulus is repeated. However, the threshold for pain is actually increased, whereby the individual is less likely to experience pain at a given stimulus than a normal individual, but when they do experience pain, it becomes excessively painful. Allodynia is the reproduction of pain by a stimulation that does not normally produce pain. This can be temperature, vibration, or other sensory input. Nociceptive pain comes from the activation of nociceptors, where neuropathic pain is associated with damage to the somatosensory nervous system. This can be either peripheral or central structures which are triggering the pain. This is also overlapping in definition with radicular pain. Central pain is caused by a dysfunction in the central nervous system. As an example, in a CVA, it is not uncommon to have the individual experience central pain. Sensitization is the changing of thresholds of input. Sensitization can occur centrally or in the periphery. In the periphery, we see sensitization under inflammation. It's much easier to trigger pain in inflamed tissue than it is in normal tissue. Central sensitization is a dysfunction within the brain, midbrain, or spinal cord, which increases the transmission of painful stimulus. Hyperesthesia is increased sensitivity to stimulation. Hypo is decreased. Neuropathy is a functional or pathologic change in a nerve. Neuralgia is pain in the distribution of a nerve or nerves, neuritis being the inflammation. In chronic pain, we see sensitization in the periphery or central nervous system and the dysfunctional states of hypergesia and allodynia. Chronic inflammation can be a cause of increased sensitivity in the peripheral system, or damage to a peripheral nerve can create what Butler refers to as abnormal impulse generating sites, or AIGs. And the dorsal root ganglion itself can become one of those abnormal impulse generating sites. In the central nervous system, there are two types of nociceptive interneurons. Some of them are nociceptive specific, the others are polymodal, or wide dynamic range cells. In the second case, wide dynamic range interneurons in the horn can become sensitized and begin to transmit nociception when they experience non-nociceptive input. This is central sensitization. Changes we see within the cortex is the normal homunculus, our brain's representation of different parts of our body, very hand and face dominant experience of the world. with the low back being small in its representation in the homunculus, gets blown out of proportion. The brain begins to pay more attention and devote more of the cortex to that structure which is painful. In the central nervous system, we see increased activity in the anterior cingulate cortex. This cortex is normally active in anticipated pain and anxiety. The wide dynamic range cells in the dorsal horn, which receive multiple types of sensory input, send their projections to the anterior cingulate cortex, which is overactivated. The anterior cingulate cortex is also involved in motor and motor planning, and it is believed that chronic pain impacts motor control. As therapists, we have a very important role as educators and empowerers of the patient to address or hopefully prevent chronic pain from developing. We have tools like the FABQ from Stephen George. We have research about whiplash and its psychogenic effects from Michelle Sterling, and a recent article by Ferreira, if that's how you say the name, speaks of a therapeutic alliance with the patient as being predictive of a positive outcome. Often, it's an issue where they have seen an X-ray or an MRI showing degenerative disc disease or spondylosis, which they are convinced by another healthcare practitioner that that is the reason for their pain. But as we discussed earlier from Bogduck's article, that this is poorly correlated with pain. Orthopedic manual physical therapy is proposed to inhibit pain by one of three mechanisms. The gate theory was originally proposed by Melzack and Wall. There is input to the system from small C fibers that transmit nociception. There is input from large A beta fibers which transmit touch sensation. There's an inhibitory interneuron within the substantia gelatinosa of the spinal cord in the second and third laminar layers. And there are second-order neurons which transmit pain information up into the midbrain and cortex. In the case where C fiber input is greater than A beta input, we see that the interneuron is inhibited, the second-order neuron is excited, producing a signal up the spinal cord to the brain. This is referred to as the gate open position. In the case where the A beta fibers are transmitting more than the C fibers, we see that the interneuron is active and inhibiting pain from going up the spinal cord. The gate, in this case, is closed, and there's no pain. This is the phenomenon associated with TENS, topical agents such as Bengay, capsaicin, and the same reason why if you rub a sore area, it feels a little better momentarily. It is believed that these large A beta fibers are stimulated by our joint techniques and can impact this system, especially if our stimulus is not producing C fiber activity. The central biasing effect is triggered by pain fiber activity or cognitive processes, including our expectations. These higher centers in the periaqueductal gray area of the midbrain and the raphe nuclei, along with the hypothalamus, are involved in endogenous opioid production, serotonin activity, and produce an excitatory input on the inhibitory interneuron, thereby decreasing pain. This is a phenomenon that is commonly experienced in cross-friction massage, which is initially quite painful and usually in normal tissue will end up feeling just like a pressure, no longer a pain. The endogenous opiate theory is not well understood. It also involves the periaqueductal gray, the raphe nucleus, the hypothalamus, and the pituitary, and is proposed to inhibit interneuron activity by a similar mechanism to central biasing. In summary, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Nociception is that sensory experience of actual or potential tissue damage. Only the cortex can value and interpret this signal into what we refer to as pain. Pain can be experienced remotely from its source. In somatic referred pain, there is an embryologic relationship between the source and the location of the experience of pain. Nociception and pain can be affected in the peripheral and central nervous systems through normal and pathologic processes, which either enhance or reduce the experience nociception and pain.